Right, so there'll be 2 weeks of wound stuff. Today I'll be mainly bugs that are aerobic, and next week we'll look at anaerobic as well as the other things that are aerobic. So the first part today is to cover 2 things that don't fit anywhere else, that is eye infections and ear infections, and then we'll go into 2 wounds in general. So eye swabs are pretty common, and we look at the eye in general, and it's an organ of high exposure to microorganisms. They're always open, apart from when you're asleep, in lectures, and they're always being exposed to microorganisms, but they tend to be uncommonly infected because we're so well protected. So overall, your host defences for your eyes will be tears, you're blinking all the time to wash your eyes all the time, and the eye surfaces are also protected and relatively inert to attack. So unless you get some kind of penetration injury that breaks the first barrier, they're pretty well resilient. So most times when we're infected in the eye, it'll be infection of the surface called the conjunctiva. That's a mucous membrane that starts at this part of your eyelid and goes all the way under your eyelid, over the eye surface, and then back over the other eyelid. On the inside, not the outside. That whole surface is a mucous membrane, and when you have conjunctivitis, that's what's infected. With conjunctivitis, most times infections are caused by bacteria that are endogenous. They're your own organisms. Things like Staph aureus, Strep pneumo, Haemophilus influenzae. That's probably the most common. As well as infections of that part of your eye, conjunctivitis will also be other infections. So keratitis is an infection of the cornea, extremely uncommon and requires some kind of traumatic implantation. So it involves either a stick in the eye or some injury to the eye to cause keratitis, because the keratinized layer is on the cornea underneath the conjunctiva. Blepharitis is a term to describe an infection of the eyelid, and that really becomes a skin infection where the skin is on your eyelid. And a good example is a stye. So a stye is an infection of the hair follicles of your eyelashes. They're painful, but not that common. The term endophthalmitis refers to infections of the actual tissue of the eye itself. Most times these come from inside, not coming outside. So they're blood-borne infections. Can be viral, can be fungal, less commonly bacterial, but really uncommon. So for us, the most common thing that we'll see in terms of laboratory work will involve conjunctivitis, and most of these are bacterial. So apart from those bacteria, H. influenzae, Strep pneumo, Staph aureus, Moraxella are a lot less common than these other 3. Some viruses are also quite common. So adenovirus is a relatively common cause of infection. Understand that conjunctivitis is extremely contagious, especially if it's viral. So you'll see signs saying you can't swim, because if you've got conjunctivitis and you swim, you put so much bug into the water of the swimming pool, it'll actually be passed on to other people in the pool. In terms of infection with the conjunctiva, it's most commonly auto-inoculation. Classic thing will be like this, and I've had this before myself. Get a cold, runny nose, you blow your nose, in your hanky, bounce back into your eye, or you do this, and you itch your eyes. Next thing you know, bugs from here are in your eye, and before you know it, you're infected. The last time I had conjunctivitis, I was actually away at a conference and I'd had a bit of a cold, and you know, did all this for business, got it into my eye, went to bed with eyes a bit sort of soggy. In the morning I couldn't open my eyes because they're so full of pus they wouldn't open. Just happens that the conference was a microbiology conference. That morning I went into the conference session, and the first guy that saw me was a clinician. He went, "Oh, your eyes are pretty sticky." He took me out of the room, down to his office, gave me a prescription and treated me. I was right within 2 days. It was awesome. And I think mine was a strep pneumo. In a neonate, things here are a little bit different. So possibilities with a neonate can include things that they might get from the mother. So classically, chlamydia and Neisseria gonorrhea can cause eye infection in neonates acquired from the mother during birth. However, the most common cause of conjunctivitis in the neonate is a blocked tear duct. The most common infectious cause might be chlamydia, given that that's the most common STI in women of childbearing age, but the most common cause in general is a blocked tear duct. One of the ways to treat kids who've got eye infections is to squirt breast milk into their eyes because it clears their tear ducts. What's wrong? It looks pretty awesome when they do it. No, seriously, it's just the coolest thing. Just go, psht. Oh, one day you'll understand. You'll be a parent one day. I know Tracy, they'll understand one day. We all okay now? I can't believe at your age to say the word breast and it's all giggly. For swabs for eye infections, if it's simply conjunctivitis, it's easy because the pus gathers so quickly on the inside of your eye, just in there. Swab is really, really easy. So you just put the swab in the corner of the eye, take the pus out, it's simple. It's much different though if you've got an infection that involves the cornea. So if it's keratitis, you've got to do a scraping of the eye. That's not done by a lab person or a nurse, it's normally done by a clinician. It's really quite scary. I only seen this done once, and they actually have your head in kind of a clamp to hold the whole thing still so you can't move. And they literally scrape the eye surface with a scalpel blade to take a scraping off it. It's really quite hard to do. If you've got an eye swab, and remember, most times, even though things can be different, most times we're talking about simple conjunctivitis and simply these bacteria. A swab comes in, a gram stain is pretty informative because you'll be able to see strep pneumo, Staph aureus, Haemophilus, and culture is straightforward. You would culture an eye swab on media to cover the most common organisms. Blood agar, chocolate agar, and conky agar. If you suspect that you might have Haemophilus as one possible cause, my question to you is like this. Would you use plain chocolate agar or would you use chocolate agar with bacitracin? You're a legend. Don't use that. Use that. You only use Choc B. The bacitracin is selective against streptococci. It's important in samples that contain other normal flora, like a nose swab or a throat swab, but an eye is otherwise sterile. And whatever's there is going to grow pretty much pure because the eye's got no normal flora. There's no point using this plate because all you're doing is adding this agent that gives you no benefit. And in fact, people don't understand that bacitracin inhibits gram-positive organisms, but also inhibits Neisseria. So if by some chance the person that you're testing may have Neisseria in the eye, and you use that, you're inhibiting one of your pathogens. So use the Choc B only when you have to, not just all the time. So the top one is viral infection. When it's viral, it tends to have less pus but much more inflammation, so it's really quite red. The middle one could either be chlamydia or gonorrhea. It's in a neonate. I think this was a photograph from somebody with chlamydia. And this one is simply the eyelid infection, and it's a Staph aureus gone up to the hair follicle there in the eyelash to infect the eyelid. The top one is actually pubic lice. Yeah, pubic lice on your eyelashes, not your eyelashes, on somebody's eyelashes. And the deal is that apparently your eyelashes and your pubic hair are the same diameter. That's important because the lice hang on with their claws, can only hold a certain diameter hair. So your pubic lice can't get on your head hair, it's the wrong diameter. It's got to be either your eyelashes or your pubic hair, otherwise it just can't hang on. I have seen this only once, and actually got a crab. So they're the nets, they're the eggs of the crab lice. I actually got an actual walking, living crab given to me, and I saved it and brought it here, lent the slide to somebody who lost it, and I'm still bitter about it. This one is a student from about 10 years ago who came to class like this, and this in him was Staph aureus. Yeah, I mean, look how his eyes are stuck together completely. Okay, so eyes are done. Ears. With ears, there's two kinds of ear infection, and they're very, very different, even though they both involve the ear, because they involve different parts of the ear. Otitis media involves the middle ear. It's the part of your ear on the inside of your eardrum. It's a disease you see much more often in infants and hardly ever in adults. And the reason being, in infants, the eustachian tube that will vent the inner ear back to your throat is very narrow and gets blocked easily. So if you think about your ear on the inside of the eardrum, it's a chamber filled with fluid that drains back to the back of your throat through the eustachian tube. While that's patent, that tube, and the draining occurs all the time, it's fine. Because anything that happens in there drains back out and the whole thing stays in equilibrium. If the tube's really narrow and you get an infection like a cold and it gets constricted and becomes blocked, then any inflammation or fluid in the inner ear can't get out this way, and that way is the eardrum, so it builds up pressure and you get an earache. So most often it's caused by a preceding viral infection that causes inflammation and blockage, and then bacteria that are endogenous to the middle ear and the nasopharyngeal area grow inside that chamber that's blocked to cause infection. So, most common causes, H. influenzae, Staph aureus, Strep pneumo, Moraxella, and quite a number of anaerobes. And they're growing in the middle ear. Because of the pressure building up, the earache really is intolerable, and kids are really, really miserable. And if you've got young children with earache, you can't always pinpoint where the pain comes from because they're just irritable and crabby, and you can't be sure why. If the pressure builds up so much that the eardrum will burst, then you'll see pus or blood either coming out of the ear or in the pillow in the morning when they wake up. You can't get pus coming out this way without the eardrum bursting. And the eardrum will heal again. So a burst eardrum, I used to think, oh, disaster, you're deaf forever, but they burst and they regrow. But you don't want them bursting all the time, because every time they regrow there'll be a bit of scar tissue. The biggest problem is this thing called gluey ear. The term gluey ear just means this chronic low-grade otitis media that gives you partial hearing loss while you're infected. If you have chronic otitis media, you might be partially deaf for months at a time. And where you've got kids with chronic otitis media, they end up with a learning deficit because for quite a fair part of their early school time, they're partially deaf. And it's really important in Australia in our Aboriginal children because they get chronic otitis media case after case after case, and they end up being, partially deaf for maybe half of a couple of years in that key learning period when they learn how to speak. The role for the lab is limited with otitis media because you can't do an ear swab, because unless the eardrum is broken, nothing's there to swab. It's only when the eardrum bursts that you then get a specimen. So the most common specimen will be just an ear swab of the pus that's come out from the burst eardrum. When you culture them, same thing. Look for things that are typical for that site. H. influenzae, Staph aureus, Strep pneumo, Moraxella. Sometimes, in cases that are complicated, they might do an aspirate of the pus from the inner ear, but that would be pretty invasive and only done if it's really, really important. With otitis externa, whole different disease. This is really now talking about the skin inside your ear canal on the outside of the eardrum. The bugs that cause this infection depends on how you acquire it. So the most common reason why you get otitis externa is from having ears that are wet in a warm climate, especially if you've been involved with any water activity where the water is contaminated. So the term swimmer's ear describes most cases of otitis externa. And swimmer's ear normally involves you have a swim, the water's a bit dirty, gets in your ear, get out of the water, don't dry your ear properly. There's now this pool of water inside your ear full of organism, and there's all the earwax there in the right temperature. Just an incubator waiting to happen. So swimmer's ear is most commonly caused by Pseudomonas aeruginosa. Classic, classic, classic. This is Pseudomonas. A number of other coliforms can cause infection, but most commonly Pseudomonas. Other possible factors may be any kind of trauma to the outer ear or to the outer ear canal. And the most common thing is your ear's blocked or your ear's itchy, so you poke things in your ear. People always say the only thing that goes in the ear should be a little finger, because that can't get in far enough to do that feels really nice. You can't get in too far to cause any damage. When you try other things for your ear is when the hassles happen. Who pokes things in their ear? Be honest. You're all liars. Yeah, I do. Car keys, great. Even your office key can get a long way in. You can get... Oh, look. Got as far as that then. When your ear's blocked, when you poke things in there, you tear the skin surface. If you tear the skin surface, you've now got skin that's open, that's prone to infection. What's the most common cause of otitis externa, apart from Pseudomonas aeruginosa, that involves trauma? What's the bug going to be? Staph aureus, classic. So, Pseudomonas is Staph aureus, and another one that's quite common, and it involves, again, warm climates usually, is fungal spores get in your ear and grow. And the other classic cause then is Aspergillus. So you plate them out, wait 3 or 4 days, and it's covered in furry growth. It's most commonly Aspergillus. So when the specimen comes in, otitis externa, think about those 3 bugs, Aspergillus, Pseudomonas, Staph aureus. So you plate them out on blood agar, Meconium agar, and maybe Sabrades agar. Sabs agar is an agar that grows most fungi, moulds and yeasts. In a gram stain of an outer ear swab, you won't see a lot of bugs usually. The gram-negative rods would be Pseudomonas. But the Aspergillus spores that you see are like small red cells, but all crunched up and crinkly. And they stain weakly gram-positive. But not a hard thing to deal with. It's somebody's eardrum. Now the eardrum should be relatively light pink and flat, This is looking from the outside, looking inwards, and you see on this eardrum, it's all red and angry, and it's bulging outwards because there's pressure on the inside of that eardrum. That's going to burst, and if that bursts, then whatever's inside that eardrum is going to come out to be culturable. Right, now looking at other kinds of wounds. So this last bit of this lecture and next week is all about the wound swab, for want of a better term. Plenty of times it'll come in, it'll be a wound swab. Now, wound can mean almost anything, depends on what's happened. It might be just a skin swab, a small scrape or a small lesion on your skin. It might follow some trauma. Could be a chainsaw injury that's got infected. Could be a post-amputation that's infected. Could be post-surgery that's infected. Could be burns in the skin that are infected. Anything that involves the swab being collected would be called a wound swab, but it can be so broad in its scope. So we can't give you a list of every single bug that might cause infection, but we'll talk about the ones that are the most common. Once you're infected on the skin, then think also about not only the location anatomically, is it on your arm or your leg or your hand, but how deep is it? It might be skin on the outside, pretty easy to deal with that. Might go deeper into the fat layers or in the muscle. Might go as far as the bone. And once you get down to the muscle levels on the bone, it becomes really, really hard to treat without having surgery. So we'll cover some of the common things. Now these terms are kind of important because often they'll come in with a swab, with a request form, describing the lesion. A pustule means a raised lump on the skin with a collection of pus at the end of it. It's got to have a yellow head to be a pustule. A papule is a raised bit of skin that's red but with no pus. A vesicle is a raised bit of skin with a head, but the head isn't pussy, it's got clear fluid. So a pustule has got yellow pussy fluid, a vesicle is raised with clearer fluid, and a papule is raised with no fluid. An ulcer really means a depression. It's a lesion that's gone deeper into the skin below the skin surface surrounding it. They're normally open and quite painful. The term cellulitis refers to inflammation of the skin that goes and extends beyond the margin of the actual lesion. So it's the redness around the lesion or the scab. We call that cellulitis. And an abscess is an internal collection of pus. Won't be a head there, but there'll be a swollen area inside all the pus, but there's no head to squeeze it to get it out. It's still internal somewhere. So that's an abscess. See there how it's angry and red, and you just almost touch that now and feel it being painful and swollen. The top one is probably more papular than pustular because it's raised, a little bit scabby, but no clear pus collection. This one is an ulcer, deep induration there around the tissue, and all this redness here, we call that cellulitis around that pustule, around that ulcer rather. Can I magnify this? How do I magnify this? Must be something to do on here. Here's a wisdom. Control plus button over there. That's twice a bit helpful today. So this is the bum, and these are pustules. So they're raised and they're pussy. Ouch. This is cellulitis. This is a disease called erysipelas. And all this inflammation there is under the skin. It's quite swollen. There's some fluid there. And the bottom one, again, is some more cellulitis around the lesion there. And this is all red around the outside. Now I've got to go Control in the minus key. We think about all the things on the skin that protect your skin from infection. So really, your skin's pretty resilient, and the most important thing is made of keratin. Most bacteria cannot infect and digest intact keratin. In fact, next semester in mycology, we'll talk about some fungi that can actually work and grow on keratin, but most bacteria can't do that. So it's got to break the skin to get to the layers below the keratinized tissue to cause infection. It's also quite dry, and you'll find you get more infection in moist skin areas than dry skin areas, so the dryness is important. And desquamation. Along comes a bug, finds some way to attach to your skin, and your skin falls off. You shed skin cells all the time. Most dust is made of shed skin cells. So the cells being shed means the bugs can't colonise long enough to get down deeper layers to cause infection. Chemically, the fats and oils you produce on your skin are inhibitory. It's got a low pH. You secrete lysozyme in your sweat. All those things are inhibitory. And you have lots of normal flora. So a pathogen's got to come along and there's lots of normal flora to cause infection first. So these bugs are common on the skin. Staph epidermidis, Propionibacteria, and Cyanobacteria. What do you know about Cyanobacteria? Only one thing. Oh, yeah, but the other ones. So there's one Cyanobacterium diphtheria that everyone knows about, but there's stacks of others that are skin flora. Cyanobacterium species other than diphtheria species. And these are common skin flora. They're gram-positive pleomorphic rods. Really, really common. And the term diphtheroid is a slang term that means a cyanobacteria that's not diphtheria, diphtheroid. And you hear it all the time, oh, it's a diphtheroid. If you can say that, oh, it's a diphtheroid, you sound as you know what you're talking about. It just means it's cyanobacteria that's cis skin flora. And Propionibacterium are the anaerobic equivalent of Cyanobacteria. They're gram-positive short rods that are common skin flora. Skin flora having anaerobes. How does that work? Surely your skin's aerobic. Look, lots of air on my skin there now. But they live deep inside the crypts around the hair follicles, and that part of your skin is anaerobic. So if you think about the idea that we've got all these defences against infection, then when you have infection, it must involve some kind of breach of those defences or some kind of impairment. So anatomically, lots of skin infections occur at hair follicles because the hair follicle is a natural breach of the skin because there's a hole there where your hair comes out that goes down below the keratinized layer of your tissues. So blocked hair follicles are a classic source of infection. So a boil often occurs when staph get down deep inside a hair follicle to cause infection of the hair follicle. So the term folliculitis just refers to the hair follicles being infected, and the bigger they get, they might become a furuncle. So a furuncle really is a boil. Rather than a small pimple, a big boil. And a carbuncle is a much bigger furuncle. Just all episodes of size. All we're saying is those basically are infections of hair follicles, and the terms change depending on how big the boils are. Any point of increased moisture gives you more risk. You'll find more skin diseases under your armpits, in the groin, got spare tyres inside the rise of your fat on your tummy. One's gone away. Got a couple there, but used to have more, but they're not too bad now. Increased moisture means the skin surfaces will be opposed to each other and rub, and the moisture means there's desiccation and you get small breaches in the skin. Anytime you use corticosteroids actually decrease the rate at which you shed your skin cells, therefore give you more old skin cells that are more prone to being infected. Increased testosterone and androgen hormones stimulate the overproduction of fats and oils in hair follicles and get them blocked. So lots of chronic acne called cystic acne is linked to overproduction of these androgen hormones that blocks the hair follicles. Any kind of cut and abrasion makes sense. If there's a hole in your skin, bus can get in, and then big trauma. And the bigger the trauma is, the more risk of infection and the wider range of possible organisms. If all you have is a minor skin abrasion, Staph aureus group A strep, that's it. Big trauma, Staph aureus group A strep, whole stack of anaerobes, coliforms, enterococci, vibrios. I mean, it just goes on forever and ever and ever. The list is enormous for wound infections, but it's a big pyramid. Most cases are caused by Staph aureus and group A strep, and the rest then is just an enormously broad range of possibilities. So look now at the ones I would call the major skin pathogens. So between 80 and 90% of any kind of pus producing, which is what the term suppurative means, are caused by Staph aureus. It's the most common thing. It's just time after time after time. Wound swab, Staph aureus. Wound swab, Staph aureus. And the reason it's so common is exposure is so likely. Up to a third or even higher of people carry Staph aureus at any one time. You may be a long-term Staph aureus carrier, maybe a transient carrier. And if you're not a carrier, somebody near you is a carrier, and they disperse their organisms. So most times it's auto-inoculation, your own Staph aureus causing your own skin infection. I am a chronic Staph aureus carrier. I'm positive. Whenever I swab myself, I'm always positive every single year. And every time I get a cut in my hand or my leg, I'm guaranteed that Staph aureus is going to get in there. And it gets in there, it's pussy and sore for a week and it goes away. These things aren't that serious as long as the wound's not that big. So very common to have auto-inoculation. When you carry Staph aureus, where do you carry it? In your nose? Whereabouts in your nose? So it's the anterior nares. So the anterior nares is the bottom part of each nostril, first half centimetre. It's just there. So nose, throat, groin, axilla, perineum. I won't demonstrate. They're the 5 most common sites you carry Staph aureus. If you want to screen somebody for possible carriage of Staph aureus, then you will sample nose, throat, groin, axilla. It's classic. The reason we want to know that is sometimes with patients who are being hospitalised, we don't care whether you are or aren't a Staph aureus carrier, but we do care if you carry a certain kind of Staph aureus, which would be MRSA. If you screen for MRSA, you normally screen at least 4 sites. It's possible to be a carrier in one site and not the other site. So you always do all 4. Nose, throat, groin, axilla, because they're easy to get to. about whether or not your infection strain is normal or not normal. So let's look at the two scenarios. I've got an infection of my skin on my arm for whatever reason, and it's Staph aureus. Do I care if it's my Staph aureus or your Staph aureus? No. I want it to go from there and be gone. Because I can treat this Staph aureus and get rid of that, and I'll then become a transient non-carrier if it was mine, because I'll kill this one and that one. But then soon after that's gone away, and I've removed the antibiotic pressure, I become recolonised anyway. If it wasn't mine, it was yours, and it treat me, then it goes away and I'm still happy. Doesn't matter. Now, if you're a Staph aureus carrier, you're a risk to yourself and to other people who've got open wounds. Does that mean if you're a Staph aureus carrier you can't work in healthcare? Doesn't mean that at all. Like there's this notion amongst nurses that, oh shit, I'm a Staph aureus carrier, my career's over. It doesn't matter, because most times if you're a Staph aureus carrier, you are not a heavy disperser of organism. It's not as though we go around blowing out clouds of Staph aureus. Most times if you're a carrier, it's there for a reason, it's happy where it is. It doesn't want to come away from your nose, it's happy where it is. As long as you take precautions about how you handle someone's wound, if you're a carrier, it doesn't matter. So there is never a need to know whether you are or aren't a Staph aureus carrier in terms of your occupation. But there are some times when there's a term called cloud babies, and some babies were known to be heavy dispersers of Staph aureus. Doesn't mean much. But if you've got a cold and you're blowing your nose and you're a Staph aureus carrier, you will disperse more organism. It's just a matter of being aware of the Staph being there. When might being a Staph aureus carrier be a problem? If you're having surgery. Now, if I'm going to have my leg amputated, I'm not too worried about that necessarily, but some things like chest surgery, open chest surgery, I don't want my Staph aureus getting in there, because if I'm in hospital and I'm in isolation, I can be protected against all the bugs coming in from other people. They wear gloves and gowns, a whole lot, and masks, and I'm all safe. And there's me on the bed with my nose right there full of Staph aureus, and I'm a risk to myself. So for some selected high-risk patients, we can decolonise them prior to surgery. And we use a cream called mupirocin. The trade name is Bactroban. Bactroban. And the active part of that is called mupirocin. And you give them this cream and you temporarily make them a non-carrier. Once you remove the mupirocin, they become recolonised and they're a carrier again. It can't make them permanent non-carriers, but can make them temporary non-carriers for the period of high risk. If you overuse mupirocin, the risk will be strains will emerge that are mupirocin resistant. So you don't overuse it. You only use that for key patients where they're at high risk. Staph aureus infections tend to be localised on a single patient and not spread. So you'll have one lesion here in your arm, it won't go anywhere else. It tends to be one lesion and stay where it is. It won't spread within that person, other than if it's really serious and it spreads systemically through the blood, but you won't get one lesion there and one lesion there and one somewhere else. It's either one lesion or one lesion in the whole body, but it won't just jump around. Now, Group A strep is a bit different. First of all, Group A strep is much less common than Staph aureus as a cause of skin infection, because less people carry Group A strep. Group A strep carriers tend to be mostly young kids, say less than 15, and adults tend not to carry Group A strep. Because it's less commonly carried, then often the source will be exogenous, not endogenous. And it's common to see the bug being spread between people, especially kids in the playground. You require a much lower dose to get infected with group A strep than you do with Staph aureus. And you often do see lesions which we call satellite lesions. One lesion there, next day another one there, another one there, another one there. There can be a whole trail of scab lesions on your arms, on your face, because it spreads within that one person as well as being spread to other people. In general, you see group A strep more commonly in warm climates than you do in colder climates. So, for example, in Tasmania, it's like this: wound swab, Staph aureus, wound swab, Staph aureus, wound swab, Staph aureus, keep going. When you find a wound swab with Staph aureus and group A strep, you go, oh, check this out, and you call people over to check it out with you. In a warm climate, it's like this: wound swab, Staph group A strep, wound swab, Staph group A strep. When you find a Staph by itself, you say, wow, look at this, Staph by itself, because it's uncommon. So warmer climates, you see a lot more of this than you do in a colder climate. Often together, though. So the term impetigo is a term to describe a particular kind of skin infection that's most common in children. And one of the reasons is kids get lots of small injuries just from normal play. And you'll see them having these scabby lesions, often on the face or the arms, exposed skin. They're red, they're itchy, they're painful, they scab over, and kids pick scabs. And when you pick scabs, you get bugs on your fingers, you touch other kids, they get your bugs and they're infected. So you see them spread amongst children. And the term school sores refers to impetigo. Classically, impetigo involves either just Staph aureus or most commonly Staph and group A strep. If you have group A strep as a cause of skin disease, think back to throat infections, and the two complications from group A strep in the throat will be rheumatic fever and glomerulonephritis. Now, with skin infections, you can't get rheumatic fever because it requires the bug's antigen to be processed through the throat, but with skin disease, you can get glomerulonephritis. Even though only a small subset of all group A streps are capable of inducing glomerulonephritis, enough of them can cause that condition that children who get chronic school sores have the risk of repeat episodes of low-grade renal impairment from glomerulonephritis. I wonder who in Australia is at the most risk. I wonder who in Australia gets most skin infections caused by group A strep. There'd be young people, there'd be in warm climates, there'd be in poor living conditions, they'd have relatively poor hygiene, there'd be it's stunning how much they get. Seriously, they always have sores on their arms, they're always infected, and you may find a kid by the time they're 10 would have had probably, I don't know, 10 or 15 episodes of skin infection involving group A strep, and if only half of those strains were strains that can cause glomerulonephritis, by the time they're 10, 11 years of age, they've got enough residual impairment of their renal function that they're on the way to renal failure. So there's a whole range of reasons why there's renal failure in Aboriginals. One will be from nephritis. Other reasons will be alcohol abuse. Other reasons might be diabetes. But overall, if I can find this bit of information, where is it? So the rate of end-stage renal failure is 100 times more common if you're Aboriginal in Australia than if you're not. That's a huge, I mean, that's just an enormous number. And it's all caused by this combination of events. And this part of it is pretty important. So one of the ways to deal with that is to try to minimise the rate at which the kids get Group A strep. But how do you do that? I mean, you can't immunise against Group A strep. And you can't make them not play in the playground and not get sores. And you can't move them away to a cold climate. So it's really quite difficult. Where's the control button? So this top one is a really, really uncommon condition, extremely uncommon. It's called staphylococcal scalded skin syndrome. If you have a lisp, it's a horrible word to try and say. I'll explain how that happens in a minute. How stupid am I? Before I was there with his mouth trying to drag it down, this little button thing can just roll it along. I didn't know that. Good, isn't it? They're school sores. You can see now how it's scabby, and you'd scratch that. Inside there would be thousands and thousands and thousands of organisms. Be highly infectious. And the bottom one, Group A strep causes much more cellulitis and inflammation around the lesion than you do with Staph aureus. So in there's almost no obvious point of infection where you can get a swab, there's no pus coming out, but under the skin, this is all Group A strep. Now it may be that a swab of the skin is negative because it's all under the skin, whereas with staph, it tends to break more often on the top of the skin, be more visible. We'll just do this last bit and then we'll have a break. So the first part is the staph scalded skin syndrome. This happens when a strain of Staph aureus infects you that makes a toxin called exfoliatin. The toxin's not that common, and it only affects children because as you get older, the toxin works by breaking the bond between this skin layer and the one below that. And the term for those things that anchors the skin to the next layer of skin, I think it's called is it a desmosome or a dermosome? Is it desmosome? Does that sound right to you? Histology? So exfoliatin breaks these bonds and the skin just peels off. As you get older, these change in their structure and become resistant to the action of exfoliatin. So it doesn't happen if you're older. It's only in young children. Very uncommon. The biggest risk from staph scalded skin syndrome is, what do you reckon it would be? The way it works with this staph, it could be a tiny little pustule just there. Toxin, blood-borne, skin peels off somewhere else. If my skin peels off, what's the risk? Other infections, yeah. So that particular episode, skin's peeled off, the staph's down there somewhere, no drama. But then the staph's in your nose and it comes out on your skin, you have a secondary infection, which is where the problem is, because of the open skin. Now, this next bit is really important. Staph toxic shock syndrome is a really, really nasty disease. Very high mortality rate. Become much more common these days, and a lot of awareness about the risk from tampon use. Now, it's important to understand how this stuff works. So lots and lots of Staph aureus make the toxin that causes toxic shock syndrome. So the toxin, toxic shock syndrome toxin number 1, there's actually 2 of them. This is the one that's most common. Most strains of Staph aureus make that toxin. Yet we hardly ever see people with toxic shock syndrome. I wonder why that is. It's like this. If I took blood from you all now and look for antibody, you'll most be positive. Because most times through our life, growing up, we have staph infection. The staph makes a small amount of toxin. Bloodstream, antibody, no drama. It's gone. It's it, done with. It's only when your first exposure happens to be a strain with conditions that promote massive toxin production as a risk. So let's look at the risk factors. It must first of all be in somebody who's not already positive for antibody. That's unusual, because most times by the time you're of age to menstruate, you're already positive for antibody and you're protected. Supposing you've gone through your whole life and you've not had a strain of Staph aureus that makes a toxin, and you're therefore non-immune. If during menstruation and tampon use, what happens then is, if you're positive for the staph in the vagina, the menstrual blood and the tampon combine to produce conditions that promote the extremely high level of production of the toxin to cause a problem. You're not already positive for antibody, you're not immune, then there's a risk. It's the low pH, the low amount of oxygen, the high amount of blood and protein, all those things induce a higher level of production of the toxin than normal. But you can get this disease from things other than tampon use. It can just be unlucky. It depends on whereabouts your infection is and whether or not the conditions are such that promote the heavy amount of toxin being produced. It can occur post-surgery in a deep wound. But the conditions that are important would be low amount of oxygen, low pH, lots of protein, and these things tend to stimulate the production of the toxin. And the toxin is what's called a super antigen, and the toxin stimulates a whole range of other downstream mediators of inflammation, and you release cytokines. You end up with low blood pressure and fluid loss. Horrible disease. Okay, let's have a breather, and we'll come back, say, is that working now? No. We'll come back at 10 past 10. It's 10 right now, so 10 minutes. Rightio. Back into it. So as well as Staph aureus and Group A strep causing skin infections, we have other things. So the term intertrigo kind of describes infections that are less aggressive and require less initial trauma that involve Candida albicans usually. So in a trigo, the infection is superficial on the very outside of the skin, no deeper involvement at all. Almost always involves any areas of opposing skin surfaces, especially where it's warm and moist. So most commonly in the groin, under your breasts if you have them, or in any fat rolls if you've got those as well. And it involves just the movement of the skin with the moisture that breaks that first skin layer, and then you get infection with Candida albicans. Where do you get that from? Candida albicans. I wonder where that comes from. Your mouth? Not really. Yeah, your gut. Almost everybody carries Candida albicans in the bowel. It's a really common organism. And in fact, next semester when we do parasitology, looking at poof parasites, it's great. Your eyes like this, you go, look for round things. That's what you train yourself to do if you look for parasites. Look for round things. And you've got to make sure you train your mind to ignore yeast because they're always there and they're round. So you go, look for round things that aren't Candida albicans as your mantra in your head. Because if you start looking at Candida albicans, everything's positive. And it's hard to avoid them because there's so many of them there. So we all carry Candida albicans. As the infection will be very red, it'll be sore, it'll weep, be quite painful, but it won't spread and it won't get any deeper because it's only Candida albicans and the bug can't go deeper than that. I never had this infection, but I remember once I used to do a lot of running when I was a bit younger. I used to have a bit more weight than I carry now, and I'd run this long run. It was, I don't know, 70 kilometres or something. And the whole time running, I'm getting sweatier and sweatier, and my thighs would rub together. When I stopped, it was so red, it was starting to bleed. And the rash was about that big, pumps on both things. And that night, I would try to go to sleep, and it was hurting, so I got a hanky and I put one there and one there so they wouldn't touch and stick together. Next day, they scabbed over, and I couldn't pull the hankies off. I had to get on a ferry to get back home with a pair of shorts on with these hankies and stuff. Like a little nappy. It looked so stupid. My only thing I regret is not having a camera to get a picture of it, but I didn't. Candida albicans, most commonly you'll see this in kids with nappy rash. This is fairly uncommon. Pseudomonas can cause dermatitis, and most commonly you'll see this in any kind of place where there's exposure to Pseudomonas and moisture and temperature. Hot tubs. So spa users get in the spa, sit there for hours at a time, it's quite warm, the skin gets all crinkly, you're breaking the skin. If it's not a well-maintained spa and you culture it, it's going to be full of Pseudomonas. Think about, you know, broths in microbiology. What do? We get a broth, add some nutrients, incubate 37, stuff grows really quickly. Well, a spa, what temperature is a spa? 37, near enough. And what's the food source in the spa? Stuff from your skin. You get in a spa and the stuff falls off you all the time. Unless you clean them and clean the filters, when you fill them with water, it's just a soup. And the more you sit in there, there's just risk. So that can be quite risky. So really, exposure there is the risk. Any kind of break in the skin will be a risk. That's all Candida albicans. And made worse because if a kid that age with a nappy is going to be moist, lots of movement, lots of disclamation. Candida albicans, it's Indotrigo, classic. This is important. So the term vascular ulcer. This is important because we get these problems all the time, if you're working in a hospital especially. In elderly people, they end up with quite low blood pressure. And it ends up that they can't get enough blood to the extremities. And this vascular insufficiency means the skin starts to break down purely because of loss of blood supply. The skin breaks down, becomes ischemic, starts to form little dents from small bangs that you do that. As you're older, you lose sensation as well. So you not only do you bang yourself more often, you're more clumsy. You don't feel it. Loss of sensation. And that won't heal because there's no blood supply. You've now got an open wound somewhere on your shins, on your feet somewhere. Open skin, open wound means bugs will colonise. Now, it's more common if you're diabetic with poor immune function, because not only do you have more risk, you've got less sensation, more neuropathy, therefore greater risk of infection. The problem with these things is the wound itself is not caused by the organism. The wound is caused by the vascular insufficiency. When you culture them and you grow something, how do you know whether what you've grown is a pathogen causing extra disease or a coloniser just hanging about? Well, you don't know. That's a decision made by the clinician. All you can do is report what you grow. Now, it may be that you grow Staph aureus. Now, if there's a wound there and you grow Staph aureus, most likely they'll treat that Staph aureus because it could be risky if you don't treat them. But the staph can also be a coloniser. In general, a staph is pretty clear-cut. It's so possibly dangerous that you get rid of a staph. But what about things like coliforms and enterococci? Things that are relatively non-pathogenic. Often they'll ignore them because if you treat the bug, the wound won't go away. The wound is there from the vascular insufficiency, not from the bug being there. It's not as though you go, great, treat the bug, the wound will heal and go away. It won't go away. So you treat them only when there's a clinical reason that that bug you think is causing more damage and needs to be removed. It's not uncommon to see things like, a Staph aureus, Enterococcus, Pseudomonas maybe, anaerobes at the same time. They're really hard to culture because there can be so many bugs there at one time. Could be 4 or 5 bugs in one specimen at one time. On top of that, the other kind of ulcers which are quite similar, called decubitus ulcers or a pressure wound. This occurs in patients who are hospitalised long term who are non-mobile. 2 broken legs or some kind of horrible disease that means you're bedridden. You lie in bed on your back. And the points of pressure means if your blood pressure isn't high enough to pump above your body weight, those areas that are flat on the bed become ischemic. Where would they be? Ankles, buttocks, and shoulder blades, because they're the bits that touch the bed. So in those patients, what's really important is you turn the patient, you rotate them. You come in, you wake them up every 6 hours, and you roll them over. Otherwise, they get pressure sores, and then they get infected. So both pressure sores and vascular ulcers are similar in the sense that the injury is caused not initially by an organism, but by some kind of vascular insufficiency, either from poor blood supply or just the pressure. And always the same thing is what you grow doesn't always mean it's a pathogen, but you report them anyway. These are horrible. So the top one is somebody's foot and they're diabetic, and that's obviously gangrenous now, but would have started with a very, very small lesion that spread and got bigger and bigger and bigger. But most of this damage is caused not by the bugs, but by vascular disease. And this bottom one is somebody who's bedridden. All of that is one big pressure wound caused by being on their back for too long and not being turned properly. If you had that wound there, what are you going to grow? Bowel flora. Enterococci, coliforms, anaerobes, all from the bowel. Impossible for this wound not to be colonised, heavily colonised. So they can be hard to culture, makes your job quite difficult. If we receive a swab in the laboratory, wound swab, I go, yeah, Staph aureus, group A strep maybe, Pseudomonas maybe. If it comes in with some hint of a marine source for the injury or the exposure, I get excited because it might be something else. What you want every day is something other than Staph aureus to make your day better. So Vibrios are important causes of infection of wounds that have been acquired in a marine environment. Vibrios are marine organisms. They grow in salt water. They like salt. So either Vibrios or Aeromonases are quite common wound pathogens if you had an injury in the water. Could be at the beach having a swim, cut your leg on an oyster. Could be fishing, cut your hand on the knife. But either way, you're talking about a marine environment where the bugs that get access to that site are from that environment. Think Vibrios. How would you recognise a Vibrio or an Aeromonas if you grew one from a wound? What do you know about Vibrios? Spirochetes, oh, what's a terrible term that, spirochete. So a spirochete's syphilis, that's a spirochete. Vibrios are curved. I wouldn't call them spirochetes, I call them curved. Curved's good. So Vibrios are curved gram-negative rods. Oxidase positive, facultative, grow big. They grow bigger than coliforms. They're big suckers. And they're often hemolytic. When you grow them, they look great because they're big and really juicy. And Aeromonases are very similar to Vibrios, from the same family. There's no need to put up special plates though. They grow great on blood agar, great on MacConkey agar. They're fine. Animal bites. Animal bites present a whole new range of organisms. Generally, cat bites are worse than dog bites. Dog bites are more common, but cat bites are worse in terms of the bugs they get in, and their teeth tend to be sharper and give you a deeper bite than a dog bite. Either way, the risk will be twofold. The first risk is infection from bugs from the animal's mouth or infection of the wound from your own normal flora because there's a hole in your skin. Some of the things that are important will be a Pasteurella moldicida is a classic cause of infection following dog or cat bite. Pasteurella is a classic organism. Gram-negative rod. On blood agar, looks and smells just like E. coli, but it's oxidase positive. It's strictly aerobic and does not grow on MacConkey agar. If I ever see from a wound a gram-negative rod and no growth on MacConkey agar, straight away it's going to be a Pasteurella. Spotindole positive. Nice bugs. When you smell them, you go, it's E. coli, but it's not because it's aerobic. Staph intermedius is a coagulase positive staph that you will probably call Staph aureus, but they are different. Whether a wound infection is caused by Staph aureus or intermedius doesn't really matter. It's really only academic. If you make a mistake and you call an intermedius a Staph aureus, who's going to care? It's not really worth worrying about. They're both coagulase positive. I can't remember from the top of my head whether this is positive by the latex test or not. It's coag positive serum with plasma rover. I'm not sure about latex tests. Also not sure about DNAs. But they're quite similar organisms. Capnocytophaga is a hard bug to grow. Capno means CO2. These bugs like to grow in CO2. They tend to cause what's called gliding motility. They're not as motile as a proteus, they aren't small over the plate, but the colonies are a bit diffuse. They spread locally around the colony. And even though the colonies themselves are not pigmented, this is going to sound bizarre, the colonies appear grey. But when you put a loop through them and pick them up, on your loop they're yellow. So the colonial mass has a yellow look to it, but the colony visually is not yellow. These are the ones I hate the most. I love all swabs except for these. A human bite or a clenched fist injury. Who gets human bites? Kids get bites because kids bite each other. And men get bites because they get in fights and you put your arm around someone's head in a headlock. What are they going to do? They're going to bite you. Or you punch them in the mouth like a bite. So we call that a clenched fist injury. Either way, what you're getting is injury to the tissue from the teeth, so penetration injury, plus exposure to mouth flora. You've all done a swab of your own mouth this semester. You know what's in your mouth. Lots of stuff, lots of organisms. So very high rate of infection because traumatic implantation, lots of bug, and deep injury. On the hand, what's worse is the gap between the tissue and the bone is tiny. So there's a risk of bone injury and bone infection. You do not ever want to get bone infection. The term for bone infection is osteomyelitis. Once the bug is in your bone, it's really hard to remove it. It needs long-term, high-level intensive antibiotic therapy. You can't just have a few tablets and it goes away. This is months and months of intensive therapy. So, what are you going to grow from a human bite? Yeah, sure, you'll like our staph, group A strep, but these things are the ones that are hard to pick up because there's so many of them. Lots of streps, just alpha streps, strep viridans, for example. Lots of anaerobes, your mouth's full of anaerobes. When you do a swab from one of these wounds, it's like a throat swab. Now with a throat swab it's easy because you go, throat swab, ignore all that crap in the background, is there any strep with hemolysis? The answer is no, you chuck it away. What if now you're saying whatever's there might be important? It's just full of stuff. So it could be these and these and these together, stacks of them. This bug in the middle called Eikenella. Eikenella, species name corrodens. They're important because they form colonies that grow on the agar and pit the agar. They corrode the agar and become almost subsurface colonies. But they're really hard to pick out. In the end, the most sensible way of dealing with these is to culture them, look hard for any dominant organism. If you can't find a dominant organism, you say this. It's a lovely cop-out phrase. 3+ mixed oral flora. The truth, but you're just not going to spend, you can spend weeks pulling out that one and that one and that one, purifying them, identifying them. What will it achieve? Not much really, because they're all going to be mixed oral flora. In the end, the therapy for this kind of injury would be penicillin because most of the anaerobes respond to penicillin, so do the streps, so does Eikenella, and there's a drug that's fully non-toxic. So unless one bug clearly dominates, it's a mixed culture that you're going to report. I'm really keen on making sure that you understand, make your work be relevant by being speedy. I would rather, as a clinician, have this report on day 2 than wait for day 10 for you to say 1 plus strep viridans, 2 plus Eikenella, 1 plus this, 1 plus that. At 10 days it's too late. It would take you 10 days to tease all these bugs out, get them pure, do all this sort of stuff on them. They won't achieve anything. So try and make your stuff be relevant by being quick where you can. Certainly Staph aureus would be. I mean, Staph aureus is aggressive and quick, grows quickly, nasty bug. If that was there, you'd know straight away. I mean, you'd culture that, it would be massive growth straight away. But of the rest, probably not. No. That's a dog bite. Big injury in there. This grew Pasteurella. Now, you've probably all heard of leprosy. Leprosy is a kind of mycobacterium that causes cutaneous disease. But there are other mycobacteria that cause skin disease that are not leprosy. And we call them non-leprosy cutaneous mycobacteriosis. And there are a couple of them that are classic. The first one is M. marinum. And as the name suggests, this is a bug that's acquired from a marine source. The term phytochromogen is a really old-fashioned term, and back in the days pre-MALDI-TOF and pre-PCR and molecular analysis, the way to speciate mycobacteria was to see if they were chromogenic or not. Did they make a pigment? And some of these things would make a pigment only in sunlight and not in the dark, and some would do it both in the dark and in the sunlight. If the bug could only do a pigmentation in sunlight, we called them a phytochromogen. So back in the day, the old days, it would be like that. Go on these bugs, plate them out on 2 plates, one in the dark, one in the light, wait for a week, look at the colour, and you put them in 2 categories. It's the first step in identification. These days, it wouldn't be done that way at all, done by MALDI-TOF or something else, some molecular probe. So M. marinum, you get a papular lesion. So the lesion is raised skin, no ulceration, no pus, just a bump. And they might spread slightly around your arm, but be unsightly, but it'd be slow. It wouldn't be like today exposure, tomorrow a lesion. It'd be today exposure, a month a lesion, 2 months a lesion, but it wouldn't go away. Most often seen in fishermen because they're exposed, bit of trauma from their fishing activities, in goes the bug, or those who own home aquariums. In there with your fish tank, washing it out, small bit of trauma, in it goes. Now, both this one and the next one are important because the bugs do not grow well at 37. They grow better at 30. And they're slow growers. Might take 4 weeks to grow them. So you can't just do a swab on blood in 37, next day look for a colony growth. It's slow. Might be a month. And it's got to be at the right temperature. So without suspicion, you won't grow them because your normal procedures will not pick up those organisms. This next one has become really important. M. ulcerans. There are 2 slang names for infection with M. ulcerans. One is called Buruli ulcer, and the other is called Bairnsdale ulcer. Who knows where Buruli is? Africa. Bairnsdale, Victoria. This is one of these bugs which I just find fascinating. So globally, there are known hotspots for this infection. Africa, and God knows why, some small town in country Victoria. Now, beyond that, it's now become more common as well in other parts of Australia. So it's common in Victoria in Bairnsdale. It's common around Phillip Island. It's common around the Mornington Peninsula, which is where I was this year, earlier on in my holidays, Mornington Peninsula. And it's common, and they're all in Victoria. So this is Victoria, Victoria, Victoria. Also common in far north Queensland in a small place called Mosman Gorge. And the reason we care is that as a disease, it's bloody horrible. So with this infection, what happens is you get a small little ulcer that starts. And you go, oh, it's not very nice. It's like a mozzie bite. Ulcerates, you ignore it, doesn't go away. After a month, 6 weeks, 2 months, it's grown to be the size of a 20-cent piece. And it's now got deeper. It's now that deep in your skin. Now, the epidemiology is still unknown to a degree, but all the advances have been made with this disease have been made in Australia. Now, one of the reasons is, this is awesome, there was one big outbreak on Phillip Island about 15 years ago, and in that outbreak, a microbiologist called, is his name Paul or Philip? Paul Johnson used to work in Melbourne as a microbiologist. He was there on holiday and one of his kids got it. Then became his passion to research it. He spent about 10 years on this bug to work out its life story. At the time at Phillip Island with this outbreak, he did a graph of all the cases that occurred in that summer and found they were all on one side of the golf course. And then worked out they were downwind of the golf course. And then worked out that what was happening is the bug was waterborne and was coming from the water reservoir used to irrigate the golf course and was being blown downwind. The story now goes that they think that the bug somehow has a reservoir in the environment. No one knows where it is. It then infects possums. There's never a link between possum poo, seriously, and the organism. And it goes from the environment into possums as a reservoir host, and then mosquitoes land on the possum poo and then bite people. It's probably a zoonosis that's transferred from possums to humans via a mosquito bite. The mosquitoes aren't infected like they are with malaria. They simply carry it mechanically on their legs. But they bite you, then you get a little welt and you scratch it. Traumatic implantation of the mycobacteria have been dumped there by the legs of the fly, or the mosquito. When you see the lesions, you'll be amazed. So this one here is M. marinum. This is the one you get from aquariums or from fishing. No big deal. But check this one out. That is M. ulcerans. That's a deep, horrible lesion. If you had that, you'd be scared, because that's now getting close to your bone. And on your shin, your bone is, oh, hear that? Just for those listening at home. If you culture that, no growth, because 4 weeks to grow a colony at the right temperature. But do a biopsy and do as Neil-Nielsen, look at the bugs there. Now, if that was TB from sputum, you'd be dead. I mean, that amount of bugs in a sputum with tuberculosis would be just horrendous. But looking in the tissue, the bug is very abundant, and you need for therapy either a combination of heat therapy, keep the leg warm, because the bug likes to grow in the 30 degrees, so you want heat therapy, a couple of antibiotics for at least 2 to 3 months, plus surgery. So very aggressive. Now, in both cases of M. ulcerans and M. marinum, you need some suspicion, because without suspicion, you won't look for the organism. You can't find these things in the gram stain and the culture. It's got to be biopsy, Zeal-Nielsen. And now for M. ulcerans in particular, you can do PCR. Do a swab, extract DNA, PCR for M. ulcerans. Much more rewarding than doing biopsies. Now, this link, which it'll be on your email because I did this morning. This link goes to an ABC story on this infection within the last 2 weeks. That's a global map showing you the hotspots in the world. Now, even though there's spots there in Africa that are hotspots, this thing's the whole of Australia. That's just rubbish. That's not quite accurate. It's not the whole of Australia. It's just a bit there in Victoria and a bit there in North Queensland. Anywhere else, doesn't happen. Tasmania, not a chance. On that graph, someone's gone, oh, Australia, you know, control input, and it's done the whole country. It's not that bad. But look at that. I mean, if that was your leg, this kid was 10. Missed half a year of school because he had to have surgery to put the hole in his leg. I mean, that would be bone. Have you ever cut your leg really badly and seen bone before? Scariest thing. I was out once, it was night time, and I was walking at the gorge, and I missed a step and went too far forward, and there's a big boulder in front of me, and my leg got stuck. And when I went forward, this part of my shin hit the rock. And because I was tensing my leg, as the rock hit it, it went, just tore open. And I had this tear that long in my shin, just there. And I thought, it's not very good, and it hurt a bit. I went home and got in the bath and just rubbed the water over it and thought, what's that white stuff there? And I touched it and thought, that's my bone. And I went all faint. It just scared me shitless. Because it was bone. It was real white bone. I could see it there. Horrible thing to think about. You can imagine right now, that is bone right there. So, after class, follow this link and read the story. It's quite illuminating. I think in the last couple of years, they've had over 200 cases in Victoria. It's not these days what you call an uncommon thing. It's now become not super common, but common enough to be a problem. And they've got to find a way to address it because you get the infection from things that are so innocuous. A mozzie bite, a small bump on the leg. And you can't predict who's going to get it. And you're seeing kids out on holidays, in the summer holidays, coming home with these infections. It takes months to happen from when you're exposed to when you're infected. So, watch this space. It's a really Australian problem at the moment. Okay. I've marked about 4 or 5 of assignment 1. Oh, they're hard to mark, gee. But I will try and get them marked this week, maybe next week. Got to get them done before you end of the unit, haven't I? I'll mark the test tomorrow, though. The test will be easy to mark because they're multiple choice. So I'll mark those tomorrow. For test feedback, how will we do the test feedback? We could do it in a tute session, or I might try and write out an answer sheet with explanations as well. Just depends what will be most time efficient for me. But certainly, I'll mark those this week, and we'll find somebody to get some feedback to give you some answers and explanations as to why you got it wrong before we do much else. When we do the feedback, or we talk more about the test after I've marked it, I'm keen to know what you think about that kind of test. I don't like them personally, because I think it's harder to examine you deeply with those sort of questions. But for marking, it's such a doddle to mark those as opposed to marking other stuff. So now I'm thinking about whether or not I might make half of the end of the exam multiple choice. I'm just not sure yet about how to go about that. And I really want to see how you all go. For example, if I look at your marks as a whole class for that test, and the average mark and the spread of marks are similar to last year, where they were short answer questions, then to me, they serve the same purpose, which means I do them easier way for me, which is multiple choice. If the marks are a lot lower than I would think, or a lot higher than I think, I've got to change my approach, but I'll just have to see how they come out with the marks. Okay? Again, after I've marked them, I want feedback about the questions, whether they were hard to understand. If they were hard because the concept was hard, I don't mind that. But if you went, what's he getting at? I don't understand. That's a bad way of writing a question. I want to know that, because often I write them and go, to me, it's as clear as mud. And you read them and you go, what's he after? I've got no idea. If that's the case, I need to know, because I need to rewrite the question for next year. Okay, so I'll see you on Wednesday.